evening and welcome to this online session on lung cancer molecular testing organized by Lung Cancer Europe. My name is Alfonso Averón and I will be moderating today's webinar. So today it is my pleasure to introduce you to our speaker, Rolf Stahel, MD. He is the president of the Foundation Councils of the European Thoracic Oncology Platform, as well as the International Breast Cancer Study Group. He's editor-in-chief of Lung Cancer and editor of Cancer Treatment Reviews, and his major research interests are clinical and translational studies in thoracic oncology. He was also chair of the Comprehensive Cancer Center in Zurich and co-chair of the Center for Lung and Thoracic Oncology and senior staff physician at the Department of Medical Oncology and Hematology at the University Hospital of Zurich, as well as titular professor of medicine at the University of Zurich until 2020. He was also a founding member at the first president of the Swiss Society for Medical Oncology, and he has served as officer in the International Association for the Study of Lung Cancer and the European Society for Medical Oncology, ESMO, where he served as ESMO national representative from 1998 to 2004. He also chaired the ESMO Task Force on Guidelines from 1999 to 2005 and chaired the ESMO Education Committee from 2006 to 2011. Finally, he was also ESMO president in 2014 and 2015 and currently is a member of the ESMO Council. So, Dr. Stahel, on behalf of Lung Cancer Europe, I would really like to thank you for your valuable and precious time today to guide us through such a hot topic as it is lung cancer genetic testing, and how does it have an impact in the treatment decision-making process to get the best outcomes for each individual lung cancer patient. So, before we get started, if this is the first time you are attending a webinar organized by Luce, I would like to give you a brief overview on the webinar dynamics. So the session will last about an hour because Dr. Stahel has to leave at 5. So during the first part, Dr. Stahel will provide a comprehensive review on today's topic, which will last from 30 to 40 minutes approximately. And then we will have in the second part some times for you to ask your questions. To ask your question, you have two ways. If you would like to make your questions live by using your microphone, you just have to press the raise hand icon in the panel of the application you just downloaded to join the webinar, and I'll unmute your microphone when it is your turn. Or if you prefer to send your questions in writing, you can do so by using the Q&A or the chat window, and I will read them to Dr. Stahel. So being said that, and without further ado, I wish you all a very fruitful session. And Dr. Stahel, the floor is yours.
Good afternoon. I want to thank first Luce very much for the invitation to be with you this afternoon on the topic of lung cancer molecular testing. Before I go to molecular testing, I want to start at the beginning. And that was in the 90s of the last century, when for the first time it was proven that chemotherapy may prolong the life of patients with metastatic non-small cell lung cancer. A lot of new drugs were developed, but then it was found that platinum combination with different chemotherapy agents, they all provided about the same outcome. And there was a big despair in the community of how can we move from there. At that time, the 1-year survival was 30%. The median survival, overall survival, was 8 months. That changed a little bit with the idea that to allocate the right treatment, we should look at the histology of non-small cell lung cancer. Basically, the two major histologies, squamous small cell lung cancer and non-squamous non-small cell lung cancer, generally adenocarcinoma or large cell carcinoma. And this happened because at that time, there was a label for bevacizumab and pemetrexed for first-line treatment of patients with non-small cell lung cancer that was restricted to non-squamous disease. This background to this was the following. The addition of bevacizumab to standard chemotherapy for the first time showed that a targeted treatment might improve the survival. It was not much, but it was a great step at that time. Also, in the publication from the JCO, there was an examination where the platinum combination with gemcitabine, which was the standard of care at that time, was inferior to platinum combinations with pemetrexed. While the overall study was negative, in the subgroup of patients with non-squamous non-small cell lung cancer, there was a slight survival advantage in favor of platinum and pemetrex combination. So based on this, from that time on, we did have to examine the histology, and the non-small cell lung cancer was not any longer adequate as a finding by the pathologist. But this, of course, changed again in the 2010s. Today, if a patient does have non-squamous non-small cell lung cancer, for 20% of those patients in Europe, there is a potential targeted treatment, which is superior to chemotherapy. So it's mandated today that biomarkers are examined by immunohistochemistry and by sequencing the DNA to find the right treatment for the right patients. And we do this currently, at least in Europe, restrictively for patients with non-squamous non-small cell lung cancer. For patients with squamous non-small cell lung cancer, it's very rare at the moment that the molecular finding would lead to a specific molecular treatment. Now, the entry of personalized therapy for lung cancer was in the year 2008. It was an ESMO meeting in Stockholm. At that time, Dr. Mock presented this study, which compared the outcome of treatment with gefitinib, an EGFR tyrosine kinase inhibitor, with chemotherapy, carboplatin, and paclitaxel, the previous standard of care, in patients with lung adenocarcinoma, pre-selected for patients who had non-smoking or a low smoking history. The study was done in Asia. After the study was done, and you see here, the results looked very strange. While there was no survival, progression-free survival overall for one versus the other treatment, the curve overlapped not. There was a discrepancy. Initially, it looked like patients who had the targeted treatment did worse. And at the end, it looked like patients who had the chemotherapy did worse. When a subgroup of those patients where tissue was available had a molecular test done, and the test was done checking for an activating mutation in the epidermal growth factor receptor, the results were seen here in terms of response rate. Patients who had a mutation in their tumor treated with gefitinib had a response rate over 70%, treated with chemotherapy, a response rate of 50%. In the absence of that biomarker, EGFR mutation, there was no response to patients with EGFR mutation, with a lack of EGFR mutation to gefitinib, versus still some patients obviously responded to the standard chemotherapy. And this study set the stage, the entry of personalized treatment for non-small cell lung cancer, and the use of biomarkers of clinical trials and all further endeavors. And the median survival here of the patient group who got the targeted treatment and did have the biomarker documented, it was 22 months in the early trials. Compare that to the 8 months where before targeted treatment was available. So biomarkers are molecular or cellular characteristics that indicate a normal or a pathological process, which can be used to help in diagnosis, to help in determining what is the clinical outcome likely to be, or more important, to define response to a specific treatment or intervention. In summary, discovery of specific mutations that predict the efficacy of a particular drug in a molecular defined tumor with a patient has greatly transformed the development of programs in oncology, changing from serendipity, development of different cytotoxic agents, to molecular targeted therapeutics. And when we speak of biomarkers, we have to keep that in consideration. There are, particularly in the clinical trial settings, biomarkers which have a prognostic and biomarkers which have a predictive meaning. I'll start with the prognostic biomarker. If you had a study with a standard treatment of one side and an experimental treatment, for example, looking at superiority of an addition of an agent, a prognostic biomarker is a biomarker that affects the standard treatment and the experimental treatment in a similar way. It has nothing to do with the selection of the right therapeutic agent. If we go to the predictive biomarker here, we have a biomarker that with standard treatment gives to the same results when the factor is there or is absent. But in the experimental group, think about again, EGFR activating mutation gives a much better result than in the biomarker negative group. Now, of course, not all is black and white, and a lot of those biomarkers have as well prognostic impact and a predictive impact. And I'm moving back to the previous slide of EGFR. You see here, the EGFR biomarker is predictive for the gefitinib activity in patients with non-small cell lung cancer, 70% versus virtually zero. However, the biomarker is also somehow prognostic in a way that it seems that the chemotherapy treatment part also seem to do better with if the biomarker is present. So it has both characteristics, but for us, for the clinician, the predictive characteristic is the key. Now, what biomarkers are currently recommended to look at in patients with metastatic non-small cell lung cancer? Its molecular targets for analysis are EGFR, ALK, ROS1, BRAF, NTRK, MET exon 14 mutation, HER2 mutation, KRAS mutations, and RET gene rearrangements. Now, why in the first study that I show you, a subgroup of patients where tissues was available for EGFR mutations, today with this many biomarkers, it doesn't make much sense to do one test after the other. So the move is to go to platform testing, next generation sequencing, so we do have information of the entirety of the biomarkers and not just of a part of it. This is an example how in Zurich this year we used to look at the tissue of patients with metastatic non-small cell lung cancer. So tissue was gained by surgical interventions or bronchoscopy. It was stained and it was determined whether the tissue was small cell or non-small cell lung cancer. In patients with non-small cell lung cancer, the next diagnostic step is to distinguish adenocarcinoma and large cell carcinoma from squamous cell carcinoma of the lung. Patients with squamous cell carcinoma, the only biomarker test that is done is immunohistochemistry for PD-L1. For all other patients, we do a rapid test, which is available in a day for mutations of EGFR, KRAS, and BRAF. We do immunohistochemistry for ALK, ROS1s, and PD-L1. And if this is not informative or partially informative, we do next generation sequencing by FoundationOne or another commercial panel. Now, the question is, and has been for a long time, is it not too expensive to do upfront testing for everybody? Wouldn't it be much more sensible to just do one test first and then do the upfront NGS testing for only part of the patient population? Now, this is a study from Asia. Patient is non-small cell lung cancer, had material at the diagnosis. So for the same patients, they went to one route, that they testing of EGFR mutation, which in their environment is 60% of the patients, and with those patients get the appropriate treatment. And NGS sequencing and PD-L1 staining was only done for the rest, for the 39% of the patients without EGFR mutation, and then they received the appropriate treatment. On the other hand, doing the other way, you could do NGS testing and PD-L1 immunohistochemistry up front and get to the right treatment for everybody. So what is the difference between the two approaches? First, it's quite a difference if upfront NGS is done for everybody. You see here, the results are available within 10 to 15 days. If patients tumor samples went to the sequential testing, the results were available only day 20 to 25. And I guess you can imagine to wait for 3 or maybe 4 weeks to get the right recommendation for the right treatment is a long time. Of course, you could say maybe it's much cheaper to do just the EGFR testing first and only NGS for those patients who do not have an EGFR mutation. But in the environment of this group, the costs were the same. Upfront NGS, $1,400 upfront, $1,500 sequential testing, $1,400, not a big difference. So it's quite clear things are moving towards direction of testing tumor tissue upfront for all oncogenic driver mutations. Now, let's go, for example, to the ESMO guidelines of upfront treatment in patients with EGFR mutated non-small cell lung cancer. What you see here, there is a number of drugs that have level of evidence 1, grade of recommendation A. Top line is osimertinib, gefitinib, erlotinib, and afatinib. Now, how to make the right choice in this situation between first, second, and third generation EGFR inhibitors? It's been a long time discussed whether the upfront treatment with the most effective agent would be superior, or whether a sequential treatment of a less expensive agent and only a switch to a more expensive agent might not give the same results. This trial, the FLAURA trial, has compared these two approaches, upfront third generation EGFR inhibitor versus first generation with a switch if the right conditions were available. While the survival data overall were not significantly different, just borderline, but you see here the approach with first line osimertinib, the most effective agents, with a median survival now of 38 months with targeted treatment. Now, with targeted treatment, all patients eventually will have a progression of the tumors due to resistance mechanisms. For first generation and second generation EGFR inhibitors, the major dominant resistance mechanism is one mutation we call T790M. This mutation can be appropriately treated with the third generation inhibitor. For all other changes, there is not an approved treatment yet, and the standard treatment is a chemotherapy with or without bevacizumab and atezolizumab. Now, for the most effective agents is osimertinib. The situation is quite different. The drug is active, the progression-free survival is much longer, but the pattern of resistance is much more complex, and there is not this one dominant resistance mechanism, except maybe amplification of MET. But you will see at the end of my talk that it's very likely that for some of these resistance mechanisms, where there is not yet an approved standard of treatment, there will be within a few years. So the ESMO guidelines recommend, what do they recommend if a patient had progressed on first or second generation EGFR inhibitors? They always recommend first to consider a local treatment, generally with radiation, if the progression is restricted to a few sites. They recommend to do a mutation testing to see whether this exon 20 T790M mutation is present. If it's present, the treatment of choice is osimertinib. And this is about 50% of those patients. If it's not present, currently still the treatment of choice is a platinum-based chemotherapy. But here I want to come to another issue is, it is quite cumbersome also for some institutions and certainly for patients to have these rebiopsies done or a new bronchoscopy done. And what has been shown is that, yes, you can get quite adequate old material also in the blood. And in the blood sample, you can detect circulating tumor cells, exosomes, platelets carrying RNA. You can look at microRNA, long RNA pieces, but all those things can be looked at. But what has become standard is to look at circulating tumor DNA and examine the circulating tumor DNA for the presence of these T790M resistance mutations. If it can be documented, it makes a further biopsy unnecessary. But we just talk about EGFR mutations, but there are many more fine points to it, and I will go slowly through this. First, the most common EGFR activating mutations are deletions in exon 19. It's about 45% of the patients. And when you look here at the curve, first generation, second generation, third generation EGFR inhibitors, all are very active in this situation. You see here in green, the second most common mutation is called L858R. It's about 40% of the patients. And here again, the first, second, and third generation inhibitors are all active in those patients. But now let's look at another situation. Let's look at exon 20 insertion, a specific kind of mutation which occurs in about 5% of the patients. Here, none of these EGFR inhibitors have activity or clinical meaningful activity. And there was a desperate search for, can we identify agents for patients which have adenocarcinoma with an exon 20 insertion. First, there are uncommon mutations, which I haven't touched now. There are mutations in exon 18, and here the second generation afatinib or the third generation osimertinib mutations have quite some activity and can be used for patients if the drug is available in a specific country. And for EGFR exon 20 insertion, there are now two drugs which have activity, which will enter clinical practice. One is a monoclonal antibody, a bispecific antibody against EGFR MET, amivantamab. The other is a targeted agent, mobocertinib. Both are active against tumors in patients with the exon 20 insertion. So you see the granularity of prescribing medicine gets finer and finer, and exon EGFR mutation is not just an EGFR mutation, but we have to look at more detail. And those details can only be determined with NGS panels. I want to go to another topic where it shows, the importance of biomarker testing and how it might affect the future in treatment. Gefitinib versus vinorelbine plus cisplatin was looked at as adjuvant treatment for patients with an EGFR mutated non-small cell lung cancer after surgery. And it looked initially that this blue curve was quite superior, so adjuvant EGFR inhibition would impact on the outcome. Unfortunately, this was not the case. While it had a slightly better progression-free survival, the overall outcome was not effective with this first generation inhibitor. But now we have osimertinib in resected non-small cell lung cancer EGFR mutation positive, the ALDURA trial. Here, with a hazard ratio of 0.17, you see a huge difference in disease-free survival in favoring of using a third-generation EGFR inhibitor. Of course, the books are not closed. It will depend what the overall survival is. But again, it's a situation where biomarker testing in non-small cell lung cancer is moving away from just being done in metastatic disease, but should also be increasingly done for patients who have earlier stages of non-small cell lung cancer. The next example I want to go with is the ESMO guidelines on treatment for patients with ALK-positive tumors. You see here a series of drugs are recommended. Level 1, recommendation A, all based on a first trial which showed crizotinib targeted treatment was better than chemotherapy. Now today, we have trials read out which again looked in comparison the first generation with a later generation ALK inhibitor, and I'm just going to give you a glimpse on the result. The first on left top is alectinib, which has the longest experience. Here now the progression-free survival for patients treated with the new inhibitor, the median was 34 months. You see there's similar data with brigatinib, it's a similar hazard ratio, and there is even more intriguing with the third generation inhibitor, lorlatinib, with a hazard ratio of 0.21. And when you look at progression in the brain, a huge difference in favor of the third generation inhibitor. So here now we talk about a 5-year survival of 63% and compare it to the 8 months before targeted treatment. And again, in ALK-positive tumors, similar as in EGFR-positive tumors, there's now trials ongoing or being designed for earlier stages of non-small cell lung cancer. And again, the biomarker testing has to move to earlier stages too. Now, just a glimpse to other targets. ROS1 is approved in Europe as a targeted treatment. We have, I give you an example of 2 drugs, crizotinib, entrectinib, with similar results, and the entrectinib even having a better CNS activity than crizotinib. We have a combination of dabrafenib and trametinib for BRAF V600 mutated non-small cell lung cancer. Similar drug combination is used for melanoma. And you see here with the combination a median overall survival of 24 months. And here we come to the current situation. You see on the left-hand side all targets that are currently looked at for targeted treatment, and you see here the number of drugs for each of those targets. So multiple targets and multiple agents for each target, which will make it a great opportunity for patients and doctors, but also quite a challenge to find out which is the best drug for a certain target. So I mentioned HER2 metastatic, mutated metastatic non-small cell lung cancer. There was no treatment up to now which had a great impact. We have here a new combination treatment. This is an antibody linked to a toxic agent with, again, the response rate of 62% and the progression-free survival of 14 months. Great opportunity for patients with the rare situation of HER2 mutated non-small cell lung cancer. It's approved for patients with breast cancer in the United States. RET fusions, there are two drugs which have just been approved for patients with RET fusion positive non-small cell lung cancer. You see, again, a response rate in the 60%, in treatment naive patients even in 85%, and response duration not yet reached. So we'll have to gear up what it will look at finally, but it's going to be certainly better than any type of chemotherapy. NTRK fusion positive non-small cell lung cancer, the larotrectinib and entrectinib have been approved. This is a very rare mutation. It's not just present in non-small cell lung cancer, but also in thyroid cancer, in childhood sarcomas, in GIST. And so it is really, here the approval is agnostic oncogenic driver approval for just NTRK targeting and not just for non-small cell lung cancer. Patients with a smoking history and adenocarcinoma very often have mutations in KRAS, and up to very recently, there is no chance of KRAS to be treated. If you look at lung cancer, patients with lung cancer, almost half of the KRAS mutations are called G12C mutations. And now there's two drugs in clinical trials, Sotosarab and Adagrasib, both targeting G12C KRAS mutated non-small cell lung cancer. You see the response rate here was 35, here is 45%. It's not as exciting yet as the targeted treatment of EGFR, but this is just the first step. So particularly also to have access to clinical trials, KRAS testing now, at least in big centers, has become standard of the workup initially. And then the last step on the targeted treatment is, the implementation of circulating DNA. Currently, the circulating tumor DNA is used for detection of T790M mutation. But there is a big promise of circulating tumor DNA to also allow monitor the disease in patients and complement the monitoring with serial imaging. We are not there yet to make treatment decisions, but I have little doubt that this monitoring of circulating tumor DNA will in the future be used to impact on treatment decisions. So the summary on the targeted treatment, chemotherapy alone, median survival 8 months, EGFR osimertinib, median survival 38 months, alectinib, median survival 5 years or more. To finish, I want to make a short glimpse to immune checkpoint inhibition. Approved in US or Europe for patients with EGFR for non-small cell lung cancer are nivolumab and pembrolizumab. PD-1 in antibodies, or atezolizumab, avelumab, durvalumab, PD-L1 monoclonal antibodies. Also approved in the US is ipilimumab together with nivolumab, and it's soon reaching approval also in Europe. Now, here, I want to start at the end and say the situation is as follows: that patients with metastatic non-small cell lung cancer who have failed the treatment of chemotherapy have a chance of a long-term survival treated with a PD-1 inhibitor. The example here is nivolumab. But the previous treatment was docetaxel. The current treatment in second line can be nivolumab, pembrolizumab, or atezolizumab. And you see here the 4-year survival in this patient is 14%. And there is the first hope that there might be some patients cured of the disease. The question has always been and continues to be, is there a biomarker which can identify patients who benefit most from the current immune checkpoint inhibitor treatment? And it has been looked at the expression of PD-L1 in tumors. It has been looked at RNA signals and at the tumor mutation burden. But to keep it simple, the only predictive biomarker that is currently used and approved is the expression of PD-L1 in tumor tissue. Why is that? And I'll show you this data on pembrolizumab. You see here first-line use of pembrolizumab in the first clinical trial in treatment-naive patients. A high expression of PD-L1, 50% or higher. You see here survival at 5 years of almost 50%. For a lower expression, the survival is about 20%. You see, for later line of pembrolizumab, after failure of chemotherapy, you also see the degree of PD-L1 expression very high, low to medium, or negative, can predict the effect of treatment. So today, patients with metastatic non-small cell lung cancer, non-squamous, molecular testing is first. Only if this molecular test is negative, PD-L1 testing or the results of the PD-L1 testing comes into play in treatment decision. In patients who have a high expression of PD-L1 in the tumor, pembrolizumab or atezolizumab can be used without chemotherapy as frontline treatment. For all of the patients with a lower than 50% expression or no expression of PD-L1, there are currently 3 options: combination of nivolumab and ipilimumab, combination of a PD-1 or PD-L1 monoclonal antibody with chemotherapy, or combination of nivolumab, ipilimumab with a reduced number of cycles of chemotherapy. This is the current standard, and the biomarker here is the identification of those patients. Now, liquid biopsy, I want to go back to, and then here, liquid biopsy is now moving very close also to the monitoring, because now we can do not just look at the quantity of tumor DNA, but we can make a tumor-informed approach when we monitor the patient's blood. And this is done when tumor tissue is available and circulating DNA is available. One can then inform the testing mechanism which mutation to look up serially, and this can be done in a personalized way for each patient. This is currently undergoing clinical testing, but is a very high likelihood of being one part of the treatment, also of immune checkpoint inhibition in the future. So I summarize. There is an increasing number of oncogenic targets identified in non-squamous non-small cell lung cancer, resulting in a need to do next-generation sequencing testing at diagnosis of metastatic disease and also extend it to earlier stage of disease. There is an increasing number of treatment options for each of the identified targets. For most of these options, it is recommended to initiate targeted therapy in first line. As exemplified for patients with EGFR mutated or ALK positive tumors, the ability to provide the appropriate targeted treatment has led to a substantial improvement of survival, and there are good indications to assume that this will also be the case in rare oncogenic entities of non-small cell lung cancer. Immune checkpoint inhibition in first line should only be considered after exclusion of targeted oncogenic driver mutations. At the current time, PD-L1 immunohistochemistry and determination of mismatch repair deficiency are the only approved biomarkers for selection of immune checkpoint inhibition. Tumor-informed serial circulating tumor DNA monitoring is increasingly investigated and is likely to increasingly become informative for treatment decisions. And with this, I want to conclude and be happy to entertain questions and discussions with you.
Thank you so much, Dr. Stahel, for this outstanding and very clear presentation. A lot of information out there and many questions that we have received from our attendees, all of them in writing. So I just wanted to remind you that you're still in time to send your questions, and if you would like to do those questions live, just press the raise hand icon and I will unmute your microphone. In the meantime, as we have like around 15 minutes for questions, I'm gonna start passing you the ones that we have received. So the first one says, in the light of potential new treatments coming for KRAS or MET mutated patients, do you think the European health system are prepared to have a proper genetic testing in place to assure patient benefit from personalized therapies for them?
Well, I think it's not a question of European, in my understanding, but different countries have different preparedness. I understand that the UK has a move to really do large-scale testing. In France, it has been done, but currently I'm not so sure how it continues to be funded. So it's going to be very different from country to country.
Thanks a lot. There is a question, I think you mentioned that in one of your last slides, but maybe it can help to reassure, which is how do you see liquid biopsy as a real option for lung cancer to improve the outcomes of genetic testing?
Well, I think as of yet, the only clinical way it is used is the T790M mutation. The situation is as follows for centers that have not such a good infrastructure to do bronchoscopy rapidly on a large number of patients. It may be helpful to have the testing on the blood done. But it's not routine yet, because at the moment, the recommendation still is initial diagnosis should be done on a tissue. How fast that will change is very hard to say.
Thanks a lot. There is another question here which says, what is the reason that next generation sequencing is not offered always as a first option, and so there are other type of tests like FISH? And this person also asks, is it because cost effectiveness or precision issues?
You see, I think what we always forgot, there is not just the science of the whole thing, but there is also a business part to it. So, you know, if a certain pathological center or institute may, I give an example, may not want to get rid of fish testing, but because it has experienced and doesn't want to get get the infrastructure out, and may still to do fish testing. So we always, when we do this type of talks, and we forget there's sometimes also a business reality which dictates how things are done.
Thanks there. Another question on the list is that there is a concept, this person says, there's a concept that I don't understand, which is molecular panel testing. Could you give a brief explanation on what it consists?
Yes, it's a predefined number of oncogenic drivers that are looked at and worked in that panel. It's not just extensive, whole DNA sequencing. It is NGS with a panel of previously predefined mutations.
Okay, so this would include the most common ones in lung cancer, like ALK, EGFR, all these.
Yes, yes. And different, different companies provide Pathology Institute with such panels. And they generally update it every time when there is a new indication out. So I'm sure now most panels are updated with the KRAS G12C mutation.
Okay, thanks, Anne. So this next one is a little longer one, and it says, as part of a breast cancer research group, you are for sure aware of how usually patients know their mutation very well, like having HER2 positive, triple positive, etc. However, in the lung cancer community, we found out that many patients don't know about their subtype, something that probably have an impact in the relation with their physician and in the decision-making process. So what do you think is the cause of this, and what ideas would you suggest to improve the situation about patients knowing more about their mutations and so on?
Yeah, but I think one situation is quite different. In breast cancer, the knowledge on HER2 is a long term, it's old, it's there for a long time. In lung cancer, the knowledge of additional mutation except EGFR and ALK is all relatively new. So it's new for, I think, physicians who are not really focusing just on lung cancer. It's new for the patient community. And the only way to change that or accelerate the knowledge is through education. So a patient should ask the doctor, what mutations have been tested.
Yeah, I agree completely that having educated patients or informed patients is good for both for patients and also for physicians. So
yes, that's true.
There I think we can play a huge role, of course. There are still 4 questions left, so unless there's still time for more, but we're going to finish on time. So the next one is, are there any updates on mutations for small cell lung cancer?
Yes, unfortunately, there is no mutation in small cell lung cancer which is currently has any high likelihood of being a target for a targeted treatment. And unfortunately, as in small cell lung cancer extensive disease, immunotherapy combined with chemotherapy has also entered the field, but no predictive marker was found. PD-L1 was not predictive, and tumor mutation or blood tumor mutation burden was not predictive.
Thank you so much. So next question is about the future of lung cancer biology. So the question says, as we know more about lung cancer biology, do you expect to find more biomarkers in the recent future? Do you think that more biomarkers will be found in the recent future?
Yeah, you see, there's 2 areas, I think, where there will be the next advances. The one is that if a biomarker like EGFR is identified, the result or the prognostic issue of that might be determined by other biomarkers that are present. For example, it's been shown that when EGFR is mutated, and P53 is also mutated, this gives a relatively worse outcome than when P53 is not mutated. So to look at a limited number, but of the environment of the target biomarkers and the other mutations will be a way to go. The other thing is, of course, on resistance mutation. It's quite clear that the newer and more effective drugs in targeted treatment seem to result in a very different resistance mutation panel than the earlier, simpler EGFR or ALK treatment. And this panel, this new panel needs to be investigated and to find out what would be the right targeted treatment for those patients with a specific resistance mutation. And the other biomarker development is certainly in predictive. Do we find more predictive biomarkers that can be clinically used for patients undergoing immune checkpoint inhibition treatment?
Great, thanks a lot. We are receiving a few more questions here. So the other one is if there is some progression or when a patient progresses, should you not always do another biopsy?
Yes, that would be the goal that to do, and the goal of the people who investigate the liquid biopsies is to find out, can you avoid some rebiopsies by just looking at the blood? Personally, I feel if the tumor is accessible and the infrastructure is there to gain a new tissue piece, it's probably more informative than just the blood. On the other hand, the circulating DNA in the blood may be a mirror of all metastatic disease, versus when you just pick one lesion and do the molecular analysis there, it may not refer to the entirety of the mutations.
Okay, so there are like the last two questions. So we'll make sure we finish in time. The first one is, have you tested to prove immunotherapy combined with personalized therapy, or is it not possible? This person says, I heard that this would be the future. Could it be?
Yes, it has been tested. And one was a test of looking at osimertinib together with durvalumab. And the test had to be stopped early because of unexpected high degree of lung toxicity of the combination. So other tests are ongoing, but one cannot just assume if two things work, you can bring them together and it doesn't have new side effects. So one has to be very careful in that regard.
Okay, and the last question, I'm trying to understand exactly, because I don't understand very well the question. I will try. It's about what's ALK mutated patients and PD-L1. Is the possibility that they can express this biomarker stop? I guess if I understood correctly, not I'm going to ask this person to send me the question again, but it's like whether maybe ALK mutated patients can also express PD-L1 and so they can benefit from immunotherapy. I think this is the question, but if I'm wrong, please, the person who sent me the question, just send that to me again.
PD-L1 can and is expressed also in tumors with an oncogenic driver mutation. We know for EGFR mutated tumor that they may have a high degree of PD-L1 expression, only that the reason they express PD-L1 is not the same reason as other tumors express PD-L1. It's not the inflamed environment, but it's a molecular issue to express the PD-L1. So PD-L1 expression in oncogenic driver tumors is not necessarily indication that the treatment will work.
Okay, that's great. Yeah, and that was the question. So thanks a lot for clarifying. So well, with that, I think we have make it on time, and we're ending at time, so you can join your next meeting. And before we close the session, Dr. Steyer, I would really like to thank you again for on behalf of Lung Cancer Europe for such an outstanding presentation and for your time. I know the agendas are tight, so we are very happy to have the chance to have you with us today and have the chance to ask you so many questions and gain so much knowledge. So thank you so much. And
thank you.
And we also like to thank you all for attending this last webinar of 2020. Hopefully next year we will be doing more webinars, but hopefully we will have the chance to meet more face-to-face. In the meantime, we will keep on committed to provide this information as we have done in the past from Lucha. So I just would like to make you a last reminder that the full content of this session will be has been recorded and will be soon uploaded to our YouTube channel. So you will receive an email with the link so you can watch it again. And also I take the chance to encourage you to follow up our activities in our website, which is www.lungcancereuro.eu, as well as to follow us on our social media channels, Facebook and Twitter. With that being said, I wish you all a very fruitful evening, and I really look forward to meeting you all shortly in our upcoming webinar. Thank you so much and have a great evening. Bye-bye.
Thank you. Thank you all. Bye-bye.